So we could have gone old school, couldn't we, Sandy? We could have done like the old school kind of debate where you both get up and you have a set of slides. But you guys, you and Kareem, RAUK 19, you did something pretty cool. And Kareem's shoes are big shoes to fill, but we're going to try. We met at ASRA this year, and we decided that we were going to kind of do things a little bit differently. So I hope that you enjoy what we've done. So this is the motion, right, Sandy?
Yeah.
If you'll go onto your Slido app, I'm hoping Dave's put a little poll. We just want to have a pre-chat vote. So if you guys get on there and just vote whether you think everybody having breast surgery should have a block. The problem with this, right, is, I mean, do we really mean everyone? In medicine, when do we ever say everybody should do anything? So that's not really fair. And are we going to be including local anesthetic infiltration on the regional anesthesia side? Because if so, I've won, right? That's easy. But let's have a look. Oh, this is a problem.
But we stacked the deck. We said everybody. Nobody, you can never say everybody. I mean, that right there, you know, it. So actually 37% did say everybody, and I just said you should never say everybody.
Now people are waking up, and oh gosh. So am I going to have to change my subspecialty after this? That's the fear. The fear is that at the end of this result, I may have to do something else, like amputations maybe. Let's have the slides back if that's possible. Well, look, let's think about what the options are. So what we're going to start off with, when was the last time you did a thoracic epidural for breast surgery?
I was probably a resident.
Yeah, I mean, I can say never.
That was a long time ago.
No, it wasn't. Paravertebral, that's probably kind of the gold standard now when people talk about regional anesthesia. And then there's this whole host of fascial planes. Obviously, I've left off about 10 other blocks that are all relevant. And then there's the paraspinal. And so, do you do any of these?
Well, occasionally, but remember, I'm the con, so no, of course, okay. all of my breast patients go to sleep.
So every time we talk about these regional anesthesia options, we're going to simplify it. We can't forget local anesthetic infiltration, but we're going to focus on these blocks. And of course, my favorite three-letter acronym, not paravertebral blocks, but multimodal analgesia, MMA. So that's what we're going to be using to focus, right? Mm-hmm. So should we get on with the cases? Do you want to tell us about this first case?
Sure. So the first case is a 24-year-old female. She's ASA1. Very healthy excision of a fibroadenoma. It's a day case surgery, relatively minor, something we all do every day.
So we're going to block this one, right? What do you think?
Oh yeah, for sure. Thoracic epidural, right?
So, I mean, this is difficult. Now, my fellows who might be in the audience will know it actually, any chance when I can put a block in, I will try to, but I mean, this is short surgery, right?
Yeah.
I can't justify putting a paravertebral in, but fascial planes are not beyond the realms of possibility, but these blocks are not that quick to do.
Agreed. I think that's the key. You have to think about your timing, your expertise, what your surgeon expects. There's all of these things that play in.
And I think the problem is if you spend more time doing the regional anesthetic than actually the surgeons take doing the operation, which does happen sometimes for me, then that's a problem. So what are we going to say? Am I going to give this one to you?
Yes.
Okay, fair enough. So Sandy wins the first round. And I think it's reasonable. It's a risk-benefit thing, and oh dear, this is not going well for me. Okay, can we go on to the slides again, please? Right, so let's have a look at the second one. So Sandy, let's look at this.
Okay.
This is a 38-year-old female who's having a lumpectomy or a wide local excision and a sentinel node biopsy. She's got fibromyalgia, chronic back pain. She might be taking opioids for these. And she has palpitations and anxiety. So I'm getting a bit excited about this because I think I may have a role. So what do you think about these options?
Yeah, I think I think if she didn't have all these extra things, I think the fibromyalgia, I think the chronic pain, the anxiety, all of those things being relatively young set her up for having pain problems afterwards. So we know that about 10% of breast patients end up with chronic pain afterwards, and she's going to be in that highest risk category. So, do I think that a surgeon can do infiltration with local and we can use multimodal? I think certainly. But I do think that if you were going to block a relatively minor case like this, she would be the one that you would do it for.
Yeah, I mean, how would you decide what technique, though? Because there was a publication by Samba recently, and they were looking at local infiltration and versus a PEX block. And for the minor surgery, there wasn't really a role for doing blocks, right? There was no difference between local infiltration. The other thing is, though, when they're saying lumpectomy, do they mean a straightforward lumpectomy? Nothing that my breast surgeons do at my trust is straightforward. Whenever it says wide local excision, normally they do these complicated diagrams and they move breast from here and put it over here, and it's quite complicated. So if it's a simple lumpectomy, then maybe I can see why you do local anesthetic, but I'm really worried about this lady. Yeah. She's got back pain. She might be on opioids, so there's a risk. Is there a benefit in doing blocks for somebody who's going to be on opioids afterwards anyway? We've heard about this.
Yeah, I mean, I think the whole goal is to minimize the amount of opioids people take. I mean, especially even for post-op nausea and vomiting, right? This group is at particularly high risk for that. And we know that limiting opioids will help. Again, I'm sealing my fate, aren't I? But I think the whole goal should be taking good care of patients. I will say that most of the literature, though, would say that good multimodal and local infiltration would be sufficient. But again, I think that this patient has some risk factors.
So what are we going to call this? Are we going to take a point each? I mean, let's have a look. I'm still not doing very well here, so this is not helping me out. Okay, guys, look, I'm going to try and convince you. I think she's got enough red flags. She's got the fibromyalgia. She's got the preoperative opioid use. I don't want her to increase the requirement of opioids she's having afterwards, so I'm going to go with a regional block, and I'm probably going to do a fascial plane block, or I might do one of those paraspinal things. There's a chap called Ki-Jinn, I don't know if you've heard of him, he's in the front row, and I was speaking to him about how I do an erector spinae plane block, but I go a little bit deeper. I do a supercharged ESP block, and I do an intertransverse processor block as well. It kind of intensifies the analgesia without exposing them to the risks of a paravertebral. So can I take a point and I give you a point for letting the surgeon
do I have to call that the Pawa block now?
Yeah, I think that's fair enough. I think we'll call that the power block. We'll take a point each, okay? If you change your mind on that poll, you get back in there again. All right, Sandy, what about this one?
All right, 64-year-old lady having a mastectomy and an axillary node dissection. She's got a history of hypertension. She's got some ischemic heart disease, atrial fibrillation. She's on a DOAC. She has asthma, and some diabetes, and some renal impairment. So a lovely first case of the day, right?
And these patients aren't that unusual now. If you look at our patient population, they're surviving with a whole host of comorbidities, and of course, they're all at risk of breast cancer. So these are the type of emails I get on a weekly basis, unfortunately. So what do you think about this? So what relevance does the DOAC have here? I mean, this is the direct oral anticoagulant drugs. Does that have an influence on what we could do?
I personally think it does. But my name's on the ASRIC guidelines for anticoagulation, so I have to say that. But no, but I do think it does. But, as we were talking before, I think that, there's no breast surgeon that wants a hematoma. So I find that this isn't usually that big of an issue because the surgeons are going to want them off for as long as I'm going to want them off. So,
so if the surgeon's happy to operate, then you'd be happy to put a block in, right?
I mean, listen, I would like to know how long she's been off, what her renal function truly is.
That has an impact, but is there? I think this is exactly the type of patient where giving them a regional anesthetic is gonna smoothen that whole recovery. And you know what? I think I'm going to throw a curveball at you. What if this lady had previous radiotherapy to the neck for thyroid cancer? I'm just going to add that into the mix, and this is actually one of my patients I've had before. So then what are we going to do now? So surely this patient shouldn't have a general anesthetic. We should do this purely under regional anesthesia.
I think that we always have to be prepared to provide a general anesthetic because we have no idea. Maybe your local goes in a place you don't think and you end up with last and you have to convert. Maybe she's super anxious and doesn't want to have this done. I don't know, in the United States, I mean, everybody says, yes, I'll have a spinal, but I don't want to know anything. I don't want to hear anything. I don't want to see anything. I don't want to, and it's like, well, then I should just probably do a general anesthetic because, so I think it really all depends on the patient, what the patient's expectations are. And honestly, if I have a difficult airway, the last thing I want to be doing is trying to secure that under the drapes with the surgeon working in that area. I would secure that airway up front.
So it's interesting, I often get asked this case, you hear about the impossible airway or the really difficult airway, and they say, well, we think, and the surgeons will say, Amit, this patient's got a really difficult airway, you must do this under regional anesthetic, or this patient can't have a general anesthetic, so you must do it under regional anesthesia. And that's a problem, right? Because what if it doesn't go according to plan? Mm-hmm. Unfortunately, I've had to do a couple of these patients where you don't want to be doing an awake tracheal intubation behind the drapes in the middle of surgery. And I can say definitely my heart rate was twice the patient's throughout the whole case. It's like the first time you do a spinal anesthetic, you put 2 mils of fluid and you think, please work, please work. So this is tricky because do you think if we gave her a general anesthetic, there's still a role to do regional anesthesia as part of it?
Oh, yeah.
See what I did there?
Yeah.
So, okay. So what are we gonna take a point each?
Sure.
Okay. So let's just have a look at the Slido call. How am I doing right now? Okay. Okay. So this is so we're gonna do blocks here, right? This is all going according to plan. Let's have a look at the next slide now, because I think...
So I think, though, for her, I mean, most of the literature would suggest that if you could do a paravertebral, that would be the block of choice, that she's going to have the best benefit from that. So I think it all depends, again, on your anticoagulation situation. But I think if you were going to do a block, that would be what you would want to do for this.
Well, the one thing I wanted to ask you is a paravertebral a deep block in this setting? Because there's a variation in some of the guidance, right? There are some guidelines that would say doing a paravertebral block, which is, we all know, the king of blocks and the block that you must do for breast surgery. There are some suggestions that if you do a paravertebral block in someone who's slightly, not clotty blood, it's okay. And then there is some guidance that you might know about which actually says, hey, it's fine. I mean, it's conflicting evidence. So how do we make these decisions? Would you have a beginner or somebody who's only done 5 paravertebrals doing one of these?
No, certainly not. I think everything we do is a risk benefit. We were talking about this, I don't know. Everything's a risk benefit ratio, right? If you think that it's going to benefit her, then maybe it's worth a little bit of a risk. But if there's no benefit, then why would you take a risk? And so I think... I'm hoping we're going to actually revise the ASRA anticoagulation guidelines, and I really hope that the next guidelines will take more of that kind of, like we did with the epidural for OB. It's really a risk-benefit decision. It's nothing's so black and white. I
think there's a reason that thoracic paravertebral isn't a Plan A block. It's not easy to do, and actually, this is the type of case where you get somebody who does these all the time to do them, right? And if you didn't have this in your armamentarium, there's still potential for you to use regional anesthesia where it's indicated. But as you say, it's risk-benefit. So I still think we're going to claim a point each.
Okay.
Now this one's a bit juicy.
Yeah.
Okay, so this is a 49-year-old female who's listed for a mastectomy and a sentinel lymph node biopsy. She's got idiopathic pulmonary fibrosis. She's awaiting a lung transplant. And actually, during the workup for the lung transplant, they found out she got breast cancer. She's really, really limited with exercise, and she's on home oxygen. This is also, sadly, not a fictional patient, but this is something that's relevant. So what are the things we need to think about here? What do you think? What's relevant? So, I mean, can we give her a general anesthetic? What do we need to know?
Well, again, I think you always have to be prepared for a general anesthetic. I don't necessarily think that it is always the best choice, but I think you always have to be prepared for it.
Yeah.
And if you're not, then perhaps shouldn't have surgery.
Yeah. I mean, I think the challenges here is, okay, we can give everybody a general anesthetic, right? That's not the issue. The issue is what's happens afterwards. But let's say we did give her a general anesthetic. Again, in this situation, can you see there being a benefit? I wouldn't want to give her an opioid-based technique, right? So I would want to be minimizing that. But do you think that doing any of these techniques and taking out intercostal muscles would affect respirations? Are these things that we need to worry about in a patient like this? Or what's the downside to doing a regional anesthetic in these type of patients? Is there a downside?
Well, the hope is that you would help with pain control because, I think opioids are not going to be good for her. I think you're going to want her to be able to breathe, not be splinting. But this is a really challenging case. This is definitely not one that you want to do in a center that you're not prepared to take care of this patient.
I mean, so obviously, if I'd seen a patient like this in my institution, there are a few people that would do regional anesthesia for this, but I don't know how many of them would do awake surgery. But I would consider taking this lady on and doing under a regional anesthesia. And if you do under regional anesthesia alone, there are some other considerations. So potentially sedating this lady intraoperatively is a concern, right? And in an ideal world, it would be great if she could have it done completely awake. Now there is a paper that's going to be coming out in BJ Education soon. We'll be talking about the issues, the things you need to think about with awake breast surgery. But I don't think this is easy. I mean, you could use non-invasive ventilation during surgery to support her. The issue is what do you do when it doesn't quite work? So I don't know. I think we both agree there's a potential role for regional anesthesia here.
I think you have to meet her. I think you have to see what she's like. I mean, there's patients that can tolerate a lot, and then there's patients that can tolerate nothing. Yeah. Right?
Yeah. And also sometimes the most simple of cases that, there may be a reason why you might want to do a block for them and someone like this, there may be some severe, contraindications to doing it. But I think let's have a look here. So for this case, wow, 69% of people would do regional anesthesia. And 0 with GA plus infiltration. I mean, listen, I looked at a textbook from Gaston Labat, and actually he invented fascial plane block. There's a picture of him lifting a breast up and taking a needle that's this big and injecting underneath the breast, and then they had the operation on the week. So regional anesthesia definitely has a role in breast surgery. I think probably in this case, look, 9% of people say it's not fit for surgery. I mean, that's something we need to think about, right? If the risk of the surgery is so high, or the risk of giving somebody a general anesthetic is so high, that actually the mortality is unjustified, that's something we need to discuss. And of course, if there's a tumour that's hormone receptor positive, there are other alternatives. But this is also the type of patient that you wouldn't want to operate on twice.
No.
So I often ask my breast surgeons why, when they've got a case like this, do they do a sentinel node biopsy? Why don't they just do the axillary node dissection from the outset? And I've never got a really satisfactory answer other than to say the potential complication of lymphedema is significant and can be so life-altering for people they don't want to do it. So let's have a look and see who's going to win this one, guys. I mean, I think it's difficult. I think we would hope to make the right decision for the patient. Let's summarize. So does everybody have to have a block for breast surgery?
No.
They don't. Every time you make a decision about doing something to a patient, you've got to look at the risks and the benefits and justify whether it's worthwhile making that interaction then. And what does the evidence say? The evidence for breast surgery, what do we know? Paravertebrals are good. If you are in the catastrophizing pain group, there's a group of patients who have anxiety scores and they catastrophize. Those patients do well with paravertebral blocks. We know that PEX blocks, there's, again, a couple of authors in the audience from some big systematic reviews looking at PEX blocks. And actually, some of the evidence suggests in the right indications, PEX blocks may actually be as good as paravertebrals for certain indications. But also, there are some cases where doing local infiltration and PEX blocks, there's no difference. Right. So why should we play around with a machine beforehand, actually, when the surgeon can do the job just as well? Also, how much pain is there going to be after surgery? That's relevant.
Yeah.
A fibroadenoma we would hope you could deal with that with paracetamol and an anti-inflammatory medication. So in some indications, there are very rare indications when I wouldn't put a nerve block in, and that's probably one of them. Right. Although we have done them in the past, haven't we? Where are my fellows? We have done them in the past, but it's a risk-benefit discussion. Right. And also, there multimodal analgesia. We talk about this acronym the whole time, but it's really important because
so important.
What it's allowed us to do things that if you give a patient decent multimodal analgesia, maybe you don't need to do a paravertebral. Maybe they'll tolerate some of these other blocks a bit better, right?
I seriously think that multimodal analgesia and the appreciation of it is probably the single most impactful thing in my career. It has allowed us to change what we do, to do blocks that are motor sparing and to do, perhaps a fascial plane block instead of a paravertebral block. So I just think multimodal is the most important thing and the one thing that you cannot ignore.
So what I'm curious to know is there's a lot of use of gabapentinoids in breast surgery. What do you think about that? Do you use gabapentin?
I don't.
I don't either. I'm just curious in the audience. Do people do that?
I'll take that back.
If you use it.
I would use it in a patient, in maybe a high-risk patient. So a patient with chronic pain, things like that, if they're taking it I may use it. But in a routine person coming in that I don't think is high risk, I don't. I think that the chance of respiratory problems, and I think it makes people really dizzy, actually. And if you want them to get up and go home, being dizzy is not helpful.
So I was having a chat with a couple of our delegates, friends of mine, John Edwards and Tom Young in the audience, and they are looking at transitional pain and trying to identify patients at high risk of chronic pain in advance. And these are the type of patients, this is what we should be doing, right? If you highlight a patient who has a risk of converting to chronic pain afterwards, these are the patients we should be intervening with. And this is maybe where something like gabapentin or making the decision to put a block in makes a difference, right? Yeah. And then again, whether you perform regional anesthesia or not depends upon what block you're doing and how comfortable you are. Mm-hmm. In your institution, are lots of people doing regional anesthesia for breast surgery?
Well, so that's what's interesting. So I work in a variety of settings. So I work at the Mayo Clinic in Rochester, which is a tertiary care center. We have every resource known to man. We've got tons of regional people. Everybody's very comfortable doing these sorts of things. But I also work in small community hospitals. And in small community hospitals, that experience and the resources aren't there. And so it's actually really interesting that even though I have the same set of skills, I don't have the same resources in different places. And so I treat patients differently, I have to admit, based on the resources that I have in that hospital.
Yeah. I mean, I think that is relevant. I mean, the issue we have is that we don't have a large enough number of people comfortable to do paravertebral blocks, but slowly we're getting people comfortable doing erector spinae plane blocks. So I think it's relevant where you do the block, but also how comfortable you are. And I think that's where these paraspinal blocks have a role. It may be your take-home meeting your take-home point for coming for a meeting like this is not I must do paravertebral blocks, but maybe I'm going to start along the journey, and you can start off by doing an erector spinae plane block first, and then when you get comfortable, take your needle a little bit further and do an intertransverse process block. And as you start to develop your skills, the next thing you know, you're able to do a paravertebral block. And there will be those patients where you do that block and it makes a big difference. So it's really important that we individualize the care, so what you're able to provide, but also identify what that patient would benefit from. And if you haven't got the skills, find somebody that can help you out, right?
Right.
So this was the motion that you were initially presented with, but I've modified it. So I think some patients having breast surgery may benefit from a block. So bearing that in mind, let's have a look and see what the final votes are. Okay, well, let's do the Amit Sandy votes. Let's see. This is an RAUK as the battle here.
Take pity on the foreigner who had to be the con in the block in the regional meeting.
Listen, I'm going to call this a tie.
Yeah,
and
okay.
I think that was really, really, really fun. Thank you for taking it off.